Subcommittee will come to order. Good morning and welcome to the Ways and Means Subcommittee on Oversight's hearing on health investigations and Medicare fraud. Fraud is a serious problem throughout healthcare, with some experts estimating that up to 10% of healthcare spending is fraudulent. That would mean in Medicare alone, that this committee has jurisdiction over, the government is spending nearly $60 billion a year in fraudulent payments. It's an incredible cost. Think about it in the context of this time of year where people are trying to negotiate different end-of-year spending plans and how much more flexibility if you had with $60 billion that weren't being literally thrown away. And this hearing is a continuation of the subcommittee's work over the past 2 years in trying to understand the causes and solutions to this incredible problem. One aspect of the problem is that not only are taxpayers impacted, but many fraud schemes actively harm patients. In the past, a lot of our discussions have been focused in on the financial aspects alone, and while finances do matter, we need to recognize that this hurts people, and one of the most egregious examples is the case of Dr. Fatah, a well-known cancer physician in Michigan. He purposely misdiagnosed people. So think about that. He misdiagnosed people, went to them falsely, told them that they had cancer, which they didn't have, and think about the heart sink of that news, manipulating them in order to provide them with treatments which he would bill Medicare and private health insurance companies for in the millions of dollars. Several patients who were perfectly healthy ended up dying because of his actions. In other instances, fraudsters may bill Medicare for opioids and other prescription drugs and then sell them on the black market. Here, not only is the taxpayer footing the bill for unnecessary narcotics, but also this contributes to the country's growing opioid and painkiller epidemic. I know nearly every member of Congress has seen this uptick, not just an uptick, an incredible high rate of activity in this area in all of our congressional districts across the country. So even when a fraudster doesn't physically harm someone, the fraud creates significant and long-term damage down the line. Many fraudsters steal beneficiaries' identities and use them to bill Medicare, another issue that Congress is dealing with and this committee is dealing with. Once a person's identity is stolen and used to improperly collect Medicare benefits, that person can be prohibited from accessing necessary care down the line because they're already in Medicare system as receiving service. So think about it. A fraudster gets your benefit, then you legitimately need something. You go to Medicare, and Medicare says, sorry, your benefit has already been used up. Well, what do you mean my benefit's been used up? It's not been used up. I haven't used it, and a fraudster has done it. So if it can be done, fraudsters are finding a way to do it. At the beginning of this Congress, this subcommittee held a hearing on Medicare fraud and improper payments from the 10,000-foot level. We heard from the Centers of Medicare and Medicaid Services, or CMS, about their methods to detect and prevent improper payments, and the results were not particularly reassuring. Despite the fact that Congress has given the agency expanded authority to stop payments before they're made, it continues to rely disproportionately on pay and chase, or making the payment and only checking after the fact to see if it was proper. One of the difficulties that we in Congress have when trying to legislate to reduce improper payments and also fraud, is how the budget process works. According to the Congressional Budget Office, or CBO, preventing the government from spending money improperly is not savings, because the money should have never been paid in the first place. I mean, this logic is just completely suspends all bits of rationality that should foster it. It makes no sense in the real world, and that's not how American families handle their own household finances. And this committee finds it just outrageous to be told in pursuing some of these things, well, that doesn't, quote, score well. The fact is, money is going out the door, and there are steps Congress can take to stop these crimes and save taxpayers from having to pay billions of dollars in payments, in improper payments and fraud. Additionally, CBS does not take into account the costs that fraud incurs in addition to the stolen money. These costs include the amount of time and resources that law enforcement needs to investigate and prosecute cases, attempting to retrieve the money already out the door in fraudulent payments, or in repairing patient harm. And no one can deny that drug crisis continues to grow. We've spent billions of dollars fighting the drug epidemic. Just a few months ago, Congress passed CARA, the Comprehensive Addiction and Recovery Act, that authorizes $620 million over 10 years to help fight the opioid epidemic. It's an important step, but we also need to focus on healthcare fraud contributes to that problem. Last year, we got a closer look at some of the tools CMS uses to detect fraud. Members of the subcommittee took a field trip, and we went up to CMS's Center for Program Integrity headquarters in Baltimore. We got to see the fraud prevention system, CMS's predictive analytics program firsthand, and we were encouraged by what we saw. But we remain concerned that CMS relies too heavily on pay and chase rather than preventing potentially fraudulent payments from getting out the door, and we hope to see greater improvements going forward. At our hearing last year, I draw a comparison between how the private sector and the government investigate fraud. In the private sector, a credit card company can detect unusual behavior and guess what whether my credit card has been stolen almost instantaneously, and this actually happened to me. A witness from Visa testified that their improper payment rate is less than 1%. And compare that to the numbers that I've been talking about a minute ago, these other that are well over 10%. But when asked CMS why it can't do the same thing, the witness from CMS said, well, Medicare claims are more complicated. And that's one of those answers at first blush you say, oh yeah, that's right, Medicare claims are more complicated. But in fact, if Medicare claims are more complicated, it's more complicated for fraudsters to make them look legitimate. So then isn't it true and doesn't it follow that predictive analytics and other data analysis would make it easier for that to be disclosed? It's important not only to save taxpayers, but also to save patients who are being harmed by these criminals. But no matter how good data analytics get, there will still be the need for investigations and law enforcement, and that's the final piece of the puzzle, and that's what we're focusing on today. We've got an excellent panel of witnesses who I will introduce in a few minutes. They have been active in detecting, investigating, and prosecuting fraud cases. Two of our witnesses worked on the Dr. Fatah investigation that I referenced earlier, and thanks in part to their tenacious work, he has been sentenced to 45 years in prison. The work these witnesses do is incredibly important, and I know I speak for the whole subcommittee, and I look forward to their insights. Now I'd like to yield to my friend and colleague, the ranking member, Mr. Lewis.
Good morning. Mr. Chairman, before we begin, I would like to announce that today is the last hearing for Drew Crouch, the Democratic Oversight Subcommittee Staff Director. This is actually the second time that Drew worked for the committee. He first joined the Ways and Means Committee tax staff in 2009 and served with us for over 4 years. Drew returned last year to be the Oversight Subcommittee Staff Director. Working with Drew has been wonderful. He is pleasant, passionate, and committed. His work is so good that others keep stealing him. But I hope that he will not forget us and we keep doing the good work, the people's work, in his next great position. Drew is a good and kind spirit, and he will be deeply missed. I want to thank him for his years of service and wish him good luck in his next position. Now, Mr. Chairman, I want to thank you for holding this hearing today. Would also like to thank all of the witnesses for being with us today. Each and every person here knows that Medicare is an important program for seniors and the disabled. 56 million people rely on Medicare to receive health care. Today, several witnesses will speak about a terrible criminal case where a doctor treated healthy patient with chemotherapy. Medicare is a key part of the very fabric of our country, signed into law by President Lyndon Johnson in 1965. What is happening is unbelievable. It is unreal. That is what makes these stories so alarming. I applaud the Obama administration on their effort to take a hard line on waste, fraud, and abuse. They launched the HEAT Task Force, which coordinates resources and information across government agencies. The administration also developed a Medicare fraud prevention system, which uses advanced technology to track possible fraud. It is also worth noting that the Affordable Care Act has stronger tools to fight fraud. These include new penalties, better funding for the Health Care Fraud and Abuse Control Account, and new screening and enrollment tools for Medicare and Medicaid. Let me be clear. People who are committing fraud in Medicare are criminals, no doubt about it. They prey on the disadvantaged, the sick, the weak, the elderly among us. Each and every one of us must do our best to fight and end Medicare fraud. Congress has a duty, a mission, a mandate, and a moral obligation to provide the necessary resources for law enforcement to investigate and prosecute these criminals. There is no doubt that the stories we will hear about are horrible, but in our fight against fraud, we must be mindful, we must be careful, and we must put Medicare patient first. Patients must continue to have access to necessary medical treatment. We must do all we can to preserve their choice of doctors and hospitals. My friend, this is not a Democratic issue or a Republican issue. This is a question of standing up for all Americans, especially for seniors and for the disabled. It is what is right, it is what is just, it is what is fair. And again, Mr. Chairman, I want to thank you for holding today's hearing and look forward to the testimony of our witnesses.
Thank you, Mr. Lewis, and I think he said it well. This is a question of standing up, and three people who have stood up are our witnesses today. The first is Barbara McQuaid, United States Attorney of the Eastern District of Michigan. You'll find two sympathetic ears and former U.S. attorneys here, Mr. Meehan and Mr. Holding. Abhi Dixit, Special Agent, Office of Investigations, Office of Inspector General, Department of Health and Human Services. Welcome. And Scott Ward, Senior Vice President, Health Integrity, LLC. You each have 5 minutes for your testimony, and we welcome you. Ms. McQuaid, you're recognized.
Chairman Roscom, Ranking Member Lewis, and distinguished members of the committee, thank you so much for inviting me to speak to you today about the Department of Justice's efforts to combat health care fraud. I am deeply honored to be with you here today. Every year, the federal government spends hundreds of billions of dollars to provide health care to the most vulnerable members of our society. And while most medical providers are doing the right thing, some exploit Medicare and other health care programs for their own financial benefit. This fraud deprives patients of resources needed to pay for medical services and places patients at risk of harm from unnecessary treatments. Medicare fraud also motivates some doctors to overprescribe opioids to patients who don't need them for legitimate medical purposes, and that's contributing to our nation's opioid epidemic. For these reasons, fighting healthcare fraud is a top priority of the Department of Justice. The department brings the vast majority of its civil cases under the False Claims Act. Since 2000, our attorneys, working with other federal, state, and local law enforcement agencies, have recovered over $1 billion every year in FCA settlements and judgments. In fiscal year 2015, the department recovered over $2 billion in civil health care settlements and judgments and anticipates matching, if not exceeding, that amount this fiscal year. Since 2009, the department has recovered over $18.5 billion in civil health care fraud cases. The department's criminal health care fraud efforts have also been a success. Beginning in March of 2007, the Criminal Division's Fraud Section, working with the U.S. Attorney's offices, the FBI, HHS, OIG, and state and local law enforcement agencies, launched the Medicare Fraud Strike Force in Miami. Based on the success of these efforts and increased appropriated funding for healthcare fraud from Congress and the administration, Strike Force operations are now in 9 areas of the United States, including Detroit. The Strike Force focuses on the worst offenders in regions with the highest known concentrations of fraud. Today, our criminal enforcement efforts are at an all-time high. In 2016, the Department of Justice organized the largest national healthcare fraud takedown in history, both in terms of individuals charged and the loss amount. On June 22nd, Attorney General Lynch and Secretary Burwell announced that the nationwide takedown, led by the Medicare Fraud Strike Force and 36 U.S. attorneys' offices, including mine, resulted in charges against 301 individuals, including 61 doctors, nurses, and other licensed medical professionals, for their alleged participation in Medicare fraud schemes involving $900 million in false billings. In addition, CMS suspended payments to a number of providers using authority provided by the Affordable Care Act. Cases included schemes to submit claims to Medicare for treatments that were medically unnecessary or never provided, or allegations that patient recruiters were paid cash kickbacks in return for supplying beneficiary information to providers so that those providers could submit false Medicare claims. The AUSAs in my own district, working with the Strike Force, have handled a wide variety of healthcare matters, and I'd like to talk particularly about the case of Dr. Fareed Fata, which Chairman Roscom mentioned. Dr. Fata was a licensed medical doctor who owned and operated Michigan Hematology Oncology, the largest cancer treatment clinic in Michigan. A former office manager at Fata's clinic reported to the department that Fata was administering chemotherapy to patients who did not need it. The investigation showed that from 2007 to 2013, Fata prescribed and administered unnecessary, aggressive chemotherapy cancer treatments and intravenous iron and other infusion therapies to patients. Some of his patients did not have cancer at all. Fata then submitted fraudulent claims to Medicare and other insurers for these unnecessary treatments. On August 6, 2013, Fata was charged in an indictment. He pleaded guilty to 13 counts of healthcare fraud and related charges. And in July 2015, he was sentenced to 45 years in prison for his role in his healthcare fraud scheme that included administering unnecessary infusions and injections to 553 individual patients and submitting bills to Medicare and other insurance companies totaling $34 million in fraudulent claims. Thank you for this opportunity to provide an overview of the department's healthcare efforts and successes. I'd be happy to respond to any questions that you might have at the appropriate time.
Thank you, Ms. McQuaid. Mr. Dixit?
Good morning, Chairman Roscom, Ranking Member Lewis, and distinguished members of the subcommittee. I am Abhijit Dixit, a special agent with the United States Department of Health and Human Services, Office of the Inspector General. Thank you for the opportunity to testify and describe the work that I and my fellow agents perform to protect Medicare and Medicaid beneficiaries and to fight against healthcare fraud. I'm here this morning to give you a field agent's perspective in the investigation of providers that defraud healthcare programs. The work of our special agents has a valuable and positive impact across the nation. During the last 3 fiscal years, OIG investigations have resulted in over $10.9 billion, 2,856 criminal actions, 1,447 civil actions, and 11,343 program exclusions. It is important to point out OIG investigations are typically conducted in partnership with investigators of other federal and state agencies as well as private sector. OIG participates in Medicare Fraud Strike Force teams that combine the resources of federal, state, and local law enforcement to prevent and combat healthcare fraud across the country. A clear example of success came in June 2016 when I and approximately 350 fellow OIG agents partnered with over 1,000 law enforcement personnel to execute the largest healthcare fraud takedown in history, involving approximately $900 million in false billings. Despite our success, more work remains to be done across the nation. To accomplish our mission, we employ sophisticated data analytics, which is a valuable tool in detecting fraud. However, it is necessary to combine the insights gained with field intelligence. Traditional field intelligence is obtained through witness and subject interviews, execution of search warrants, and surveillance, which is critical to reveal the scope and nature of the fraud scheme and whether patients are being harmed. I would like to emphasize that Medicare fraud is not a victimless crime. It's not just about the loss of taxpayer dollars when fraud is committed. Medicare beneficiaries can suffer physical harm. One case of which I was personally involved is of a Detroit area hematologist-oncologist, Dr. Fata, who was sentenced last year to serve 45 years in prison. Dr. Fada used false cancer diagnosis and unwarranted dangerous treatments as tools to steal millions of dollars from Medicare. Let me describe my work as a field agent for this case. The initial phase of the investigation, determining whether the allegations were credible, lasted just 5 days. Near real-time data was retrieved and analyzed to identify witnesses who could give us more information. As evidence was uncovered, it became clear that patient-related decisions were made to maximize reimbursement rather than to advance the best interest of the patient. At this point, traditional law enforcement techniques were deployed, and a command post was set up to relay information directly and immediately to a prosecution team. On the 5th day, Dr. Fada was arrested and 6 search warrants were executed. OIG special agents are specifically trained to identify and address potential patient harm and work with law enforcement team prior to the execution of the operation to protect patients. In conjunction with DOJ and the FBI, a victim assistance hotline was set up to provide round-the-clock information to affected patients. We also deployed additional staff to each operational site that morning. While such stark cases of direct physical harm and the pursuit of profit, like this one, are not the most common, it is far from the only example. Another priority for the OIG is the enforcement and prevention of prescription drug fraud. In one example of prescription drug diversion, a Michigan pharmacist, Mr. Patel, and a network of pharmacies were among 37 defendants convicted for their roles in a widespread scheme to defraud Medicare and Medicaid of nearly $58 million. In conclusion, I would like to underscore the commitment of the OIG in protecting program beneficiaries and fighting healthcare fraud. The highly specialized investigative work of our special agents, combined with cutting-edge data analytics, continue to prove effective in making a valuable and positive impact. Thank you for the opportunity to speak to you today. I'd be happy to answer any questions.
Thank you, Mr. Dixit. Mr. Ward?
Good morning, Chairman Roscoe, Ranking Member Lewis, and distinguished members of the subcommittee. I'm Scott Ward, Senior Vice President of Health Integrity and Program Director of ZPIC Zone 4. I am here today, and I appreciate the opportunity to tell the committee about the important work that we do for the Centers for Medicare and Medicaid Services in protecting the integrity of the Medicare and Medicaid program. Health Integrity is a nonprofit corporation incorporated in 2006 and is a wholly owned subsidiary of Quality Health Strategies. Our corporate headquarters are in Easton, Maryland, and we have offices located throughout the United States. We have 285 nationwide employees, and we also have a large resource pool of statisticians, data analysts, predictive modeling specialists, medical directors, nurses, certified coders, subject matter experts on policy, communication specialists, auditors, and investigators. Our staff understands the healthcare delivery system and the differences in provider fraud, waste, and abuse actions across all provider types, in all settings, and in the fee-for-service and managed care payment environments. We also understand how fraud is committed and how abusive practices lead to poor and inadequate patient care and program vulnerabilities. We also know how beneficiary and provider improper actions cause wasteful expenditures of program funds and ultimately improper payments. Our contracts with CMS include all aspects of the Medicare program integrity operation. We're the zone program integrity contractor for Zone 4, which investigates fee-for-service claims for Medicare and Medicaid in Texas, Oklahoma, New Mexico, and Colorado. We're also the National Benefit Integrity Medicare prescription drug contractor with a responsibility to identify and investigate incidents of fraud, waste, and abuse in the Medicare Advantage and Medicare prescription drug programs. We also have the Audit Medicaid Integrity contractor that identifies Medicaid overpayments in 34 states and the District of Columbia. Additionally, we hold a UPIC IDIQ as well. Health Integrity was awarded the ZPIC Zone 4 contract on September 30th, 2008, and was the first ZPIC awarded by CMS. The primary focus of the ZPIC is to protect the Medicare Trust Fund by preventing, detecting, and deterring fraud, waste, and abuse in the Medicare and Medicaid programs. The ZPIC's authority includes investigating and analyzing Medicare Parts A, B, durable medical equipment, home health, hospice, and the Medicare-Medicaid data match programs operated in conjunction with state Medicaid agencies. These investigative activities are conducted through proactive and reactive methods and actions that may be taken to correct these problems to help ensure that future fraudulent billing practices or improper payments are not made. Investigative leads are both reactive and proactive. Reactive leads are identified from outside source complaints, such as referrals from Medicare Administrative Contractor, beneficiary complaints, ex-employees, Office of Inspector General hotline complaints, and the CMS fraud prevention system. Proactive leads are identified through data analysis, local knowledge, subject matter expertise, and policy review. During Health Integrity's investigative process, Health Integrity is constantly looking to implement any available administrative action that can be taken to effectuate a correction or elimination of the identified fraudulent or abusive claim submission or medical service scheme. The ZPIC uses multiple tools to combat fraud, waste, and abuse. These efforts are effective through our collaborative partnerships with CMS, law enforcement, and other stakeholders. The work the ZPIC does is an important function in the overall CMS effort to combat fraud, waste, and abuse in the Medicare and Medicaid programs. We are proud to our contributions we have made in this process. This concludes my statement, and I'd be welcome to take any questions you may have.
Thanks, Mr. Ward. Thank all of you. I think it's so interesting. We have a lot of questions for you, and the first person that you'll hear from is Mr. Holding.
Thank you, Mr. Chairman. Mr. McQuaid, Mr. Dixit. Truly a notable case, the FATA case. Mr. McQuaid, how did you originally find out about the case? What was the trigger that got you looking at Dr. FATA?
The Dr. FATA case came to us from a whistleblower. The office manager in his office was someone who heard from some of the doctors, noticed that some of them were resigning, and found out that Dr. FATA was prescribing unnecessary medical treatment. So he came into the office, and as Agent Dixit said, we took it very seriously. We frankly thought it sounded too outrageous to be true, but we knew that if it was true, we needed to act quickly. And so I'm very proud of how hard the agents and prosecutors worked around the clock to be able to take him down within 5 days, to make sure that, as Ranking Member Lewis has said, patient care needs to be of paramount concern, and it was in that case, and that's why I'm so proud of the work of those prosecutors and agents.
I mean, did you have a grand jury open looking at fraud and just plug that in there? Did you bring it to a grand jury, or did you just have enough evidence to go and get an arrest warrant?
We charged him in a complaint initially, and then continued to investigate additional incidents, continued to talk to additional witnesses, and ultimately presented it to a grand jury. But we were able to act quickly by charging him in a complaint and executing the 6 search warrants on a Tuesday morning. One thing that was very important to us was making sure that patient care continued. And so, again, due to the good thinking of the agents and the prosecutors, came up with a protocol so that patients could obtain their patient records and patient files even after they had been seized by agents, so that they could take them to another cancer provider and to ensure continued patient care.
And how long? So it was a period of 6 years that he'd been doing this, $34 million, multiple patient deaths. Mr. Dixit, you referenced sophisticated data analysis that you all use, I assume, to proactively look for fraud. So how was he able to elude your sophisticated data analysis for so long to such a great extent?
Thank you for that question, Congressman. Data analytics is a very valuable tool, as I stated in my statement, but it has to be combined with field intelligence. We do, along with the ZPIC and CMS folks, we actually do a lot of proactive work. But however, unless you actually go to the field and find out who the actual provider is, how many providers are in that particular practice, all we know is that he will be an outlier. That's indicative of fraud, but it's not necessarily fraud, does not rise to an investigation.
So in the scope of your work, when you see an outlier like that, what do you do?
We further the investigation. We combine it with surveillance. We find out, we get a better picture. We have ZPIC and folks, analysts who are experts in data analysis. We find out, is it one provider billing, say, $30 million, or is it 10 providers billing $30 million? Makes a big difference. Once he's an outlier, we start doing our investigative techniques like surveillance, talking to witnesses, beneficiaries, and we get a better picture whether or not we should proceed on the criminal side.
Can you give me some idea of the the scope of outliers out there that you would be looking at on any given quarter, month?
I can't exactly quantify it with a number, but I can give you an example of one of the cases I worked, which came straight from a proactive data analysis system. We had a physician in Michigan who, through proactive data analysis, the ZPIC actually forwarded it to us, stated that if this provider would have provided these services, that particular doctor would have had to travel 450 miles in that one day and perform 36 hours of services, which is practically impossible. Yes, we opened a case for further investigation, and that individual was indicted and convicted.
Mr. Quaid, did this go to trial?
No, the case did not go to trial. Ultimately, Dr. Fata entered a guilty plea and was sentenced to 45 years in prison.
During the process of negotiating that, did he raise a defense at all?
He really did not. He ultimately, at his sentencing hearing, he admitted to the judge that he had been motivated both by greed and by power. So it was an interesting statement on his part. But he never really mounted much of a defense. I think his goal was mitigating his sentence at the end of the day. But we were pleased that the judge imposed a sentence, although we sought a higher sentence, a sentence of 45 years, which for a 50-year-old man is a substantial sentence.
All right. Mr. Chairman, I yield back.
Mr. Lewis.
Well, thank you very much, Mr. Chairman. Let me thank each of the witnesses for being here. Could you tell me, maybe just speculate, what motivate doctors or other medical professionals to engage in fraud, Medicare fraud? Is it simple greed? People have to conspire, have to engage in a conspiracy to get doctors and other health providers, pharmacists and others?
I apologize. Thank you for that question, Congressman. What we see in Detroit, what I have seen personally in Detroit, I will give you an example which will make a better point of this case. We worked a home health agency case where the defendant out of 20 defendants that were indicted in that $13 million case. The defendant was arrested. The day of his arrest, he was interviewed. He cooperated with law enforcement, and he told us that he was not a medical professional. He worked at a Church's Chicken. For him, it was easier to get into the field, sign up with Medicare, and start billing for services that were never rendered. However, he did learn the scheme from a different home health agency owner and wanted to start it his own because he did not want to make just dimes and dollars. He wanted to make millions of dollars. So that's one part of it. We also see another part of it where individuals that try to do the right thing in the beginning get sidelined because there's a lot of fraud. And fraud is a problem. I mean, obviously we all know that fraud is a problem, but we do have doctors who have come in and proffered with U.S. attorneys and agents who tell us that it was impossible for them to actually perform the services without getting involved. Did they stop? No. So were they convicted? Eventually, yes. Greed got the better of all of them at one point, but the motivation we see in Detroit is all about money.
Well, is organized crime involved?
We see a variety of cases. We see simple folks who have no medical background all the way up to sophisticated doctors like Dr. Farid Fata. And this particular case that I was talking about, the home health agency case, we had 4 home health agency owners, 3 doctors, physical therapists. They all operated exactly like a criminal enterprise. One would not do without the other. One had to do, for example, the physical therapist had to make up these sheets if Medicare came looking whether or not the service was provided. It was all done on the back end. They would bill Medicare up front, but all the fraudulent paperwork, everything else was done on the back end. Everyone served a purpose. It was a criminal enterprise, yes.
Others like to comment?
Congressman Lewis, I don't know that we see traditional organized crime groups being involved in Medicare fraud, but as Agent Dixon said, there are sometimes very complex and sophisticated conspiracies designed to defraud Medicare and other insurance programs. And I do believe that the motivation is greed, that there is substantial money to be made And that is what motivates this work. Another case that we had that does result in patient harm and harm to the community involved a doctor in Monroe, Michigan named Oscar Linares, who set up what can be described as a pill mill. And I am certain that he did it for greed, because he used his funds to buy things like Rolex watches and luxury vehicles like a Bentley and a Ferrari. And so I believe that his motivation was greed. But he was prescribing oxycodone pain pills to people who did not need it for medical necessity. He saw more than 250 patients a day and was putting these pills out into the community. And in exchange, he would have the patients submit to unnecessary medical treatment or unprovided medical treatments for which he would bill Medicare. So he made a lot of money, and in the process, many, many people were provided with prescription opioids that I believe contributes to our nation's opioid epidemic. And as you know, it is a gateway to heroin use and overdose deaths. So it is a serious problem that does, as you have said, impacts patient harm.
Thank you. You're back.
Mr. Rice, South Carolina.
Thank you, Mr. Chairman. Medicare is certainly a noble and essential program provided by the federal government. It's a promise made to our seniors, and we have to make that promise solid and keep it and make sure it is kept. It's also one of the largest and most expensive programs run by the federal government. We paid more for Medicare services in 2015, about 20% more than we paid for our national defense. And with $20 trillion in debt, we have to make sure that those dollars are spent wisely, obviously. We have to eliminate every drop of fraud that we possibly can. I know that 99% of the people using Medicare are certainly honest and deserving people, but there are always crooks out there, and I appreciate very much what you do to detect those and to bring them to justice. The FATA case is an example that it's shocking to everybody that he could bill, I think it was $60 million, is that right? Over 6 years, and not be detected until a whistleblower came along. Mr. Dixit, why is it that a whistleblower had to come along? How long would it have been had that whistleblower not come along? Had somebody within his practice not come and turn him in, how long would it have taken us to detect this astounding level of fraud?
Thank you for that question, Congressman. And unfortunately, I do not have an answer for that. Unless the office manager or citizens that are concerned or beneficiaries that see fraud happening, unless they come forth, which is one of our main sources of referrals, along with OIG hotline, referrals from ZPIC, proactive data analysis, I wouldn't be able to tell you with any assurance that anybody would have come forward or we would have found that particular issue.
Okay, well, can you tell me, we have these tools for predictive analysis. Can you tell me what percentage of these fraud cases are brought as a result of predictive analysis versus whistleblowers, people coming forward and fessing up?
I can't quantify a percentage, but I would be happy to get back to the subject matter experts who actually work in this area and get back to you at a later date with a percentage.
I'd love to see that. I would love to know. That would give me some indication of the effectiveness of the predictive analysis. Mr. Ward, I think your job is detecting this fraud, right?
Yes, sir.
You talked about outliers. You look at statistical analysis of Medicare providers, I suppose, and you look at things that just don't make sense, right? Look at outliers.
That's
Is
correct.
there a procedure for auditing those outliers? I mean, do we have an ongoing, like the IRS, annual audit procedure where we select providers for review?
Yes, that actually occurs at the Medicare administrative contractor level. The contractor that actually pays the claims, they do, on an annual basis, they develop a probe plan of audits that they're going to conduct on specific services that are billed when they do data analysis, and then they coordinate with the ZPICs to determine areas that they think could potentially be fraudulent, as well as they review the OIG's annual plan for areas that they're going to focus on.
All right, so can you coming back to you, Mr. Dixit, can you tell me, as a result of these audits, what percentage of the criminal prosecutions that you do are as a result of these audits versus whistleblowers versus predictive analysis?
Well,
Mr. Dixit.
Thank you again, but once again, I can't quantify the number in terms of percentage, but we would be more than happy to get back to you. We have data analysts who actually work in this field, and we'll get you a percentage for sure.
Thank you. Mr. Ward, in the process of these contractors that you say are doing the audits, so the government is hiring independent contractors to do the audits. The government is not doing it itself, right? Is that what you said?
That's correct.
All right, so do you know the mechanics of choosing who they're going to audit? Do they focus on outliers? Do they do random audits like the IRS? Do you have any idea of the procedure?
My knowledge of how the Medicare Administrative Contractor develops that is limited. They do statistically valid sampling. They look at areas where maybe there's overutilization in certain claims, code types, different where there's billing spikes, things of that nature, and then they determine from that who they might probe.
My time's up, but I have one more question for you, and that is, based on your, I've read this memo, and it says that we don't have a good number on what the actual fraud is, but that's your job. So I would just like your opinion. What percentage of the actual fraud and abuse are we catching?
Are you talking about nationwide or just the area?
Nationwide.
That would be hard for me to give a
Is
answer.
it more or less than 50%?
Probably less than 50%.
Thank you, sir.
Mr. Crowley of New York.
Thank you all. I'm going to be very brief, but thank you all for your testimony this morning for the committee. I want to thank the chairman and the ranking member, all the members, for continuing to delve into what is has been a historical problem facing our nation, that is Medicare fraud. Ms. Dixit, I applaud your work in protecting beneficiaries from Medicare fraud every day. Thank you to all of you for what you do every day. This is important work that you're engaged in, and you outline very clearly how fraud harms beneficiaries as well as the taxpayers, and in some of these cases horrendously in terms of poisoning, literally poisoning people, not only with opiates, but with other drugs intended to fight cancer that would, in their own nature, are in essence poison themselves to kill those bad cells. The Affordable Care Act added several important tools to fight against fraud, always knowing that those who are intent on committing fraud will find ways around the law. But we did give it additional tools. It gave increased funding to combat fraud, provided new tools to screen providers so that we can prevent criminals from getting into the system on the front end, improved data analytics, and instituted more payment review to check for problems before money goes out the door. Mr. Dixit, can you talk about how increased funding, improved data analytics, and more fraud-fighting tools has helped you do your job?
Thank you, Congressman. Data analytics, as I stated earlier, has been extremely powerful tool for agents to analyze and detect fraud. At least they're indicative of fraud, combined with agents and resources on the ground. We work with state and local law enforcement. Data has always pointed us in the right direction, combined with agents going into the field and following up on surveillance techniques to get a better picture of what we are actually seeing has helped us immensely. So data analytics, the more analysis we do on data, we figure out where the problems are. We can identify geographic hotspots. We can identify, for example, if there's a physician billing for services and is in cahoots with a home health agency owner, we can actually do data analysis to see who the highest paid home health agency is through data analytics. Of course, we will have to combine that to see, because the data analytics is not going to tell us whether the home health agency owner is paying any kickbacks to that doctor. So combined, it's a very valuable tool.
And it's one of a number of tools that were added through the Affordable Care Act, is that correct, including additional funding and other tools to fight fraud?
I cannot speak to the funding portion of it. I'm a field agent, so my expertise is limited in the funding portion as to what we're getting regarding where the funding stream is coming from. But I can have the folks at our office headquarters get back to you on that particular issue.
I would suggest additional funding has been made through the Affordable Care Act, the passage thereof, to help you fight the fraud that you're involved in every day. So on behalf of the American people, I want to thank you for your efforts, all of your efforts in that vein. I yield back the balance of my time.
Thank you. Mr. Reed of New York.
Thank you, Mr. Chairman. And before I get started, I just want to kind of put in perspective what we're talking about here. We're spending about $600 billion, is my understanding, looking at the material before me on Medicare. The improper payments, including fraud payments, totals about $60 billion, I think is what the reports show us. And out of that $60 billion, there's a debate whether it's 18 to 50% of it is actual fraud, and as opposed to just improper billing situations, which is also an issue which is outside the scope of this hearing today. But just to put that $60 billion figure in perspective, we're talking about an amount of money that's twice the level, at $60 billion, that the entire U.S. government spends on the National Institute of Health. National Institute of Health is a leading public agency trying to find cures for some of the most devastating diseases amongst us as American citizens. It's 3 times as much as the NASA budget. Not Nassau, that's in New York, and my colleague from New York had me thinking of that. NASA budget. It's about the size of my home state of New York State Department of Parks and Recreation budget. All the money we spend in New York State for our parks and recreation services for the entire state of New York is equivalent to what we're talking about here today. And so what I'm very interested in looking at, and Mr. Ward, I'm very interested in your testimony that you've submitted here, because I am, too, also a firm believer in data analytics, predictive analytics, the algorithms that go into the software that create that analytic possibility. So I just want to ask because you're the contractor, you're the contractor that is utilizing a lot of these analytics on a day-to-day basis, is my understanding from your testimony. Is that correct?
Yes.
Okay. So I just want to make sure, are there any issues with the data itself that you're getting from CMS, from Medicare, that is a problem in order for you to run it through that computer software analytic program, the algorithms that are there? Are there any data exchange? Are you getting the data you need in order to input that into the system?
Yes, we are actually getting the data.
And the data comes in a way that you can read it and run it through the programs?
Yes.
Okay, that's very good to hear, because we haven't heard that in other agencies and departments. So let's talk a little bit about what other data could you be interested in looking at that would improve the analytic capacity that you have as a contractor looking at this issue?
Well, in addition to the Medicare claims data, we do have some abilities, and we have been looking at areas of using, like doing web analysis to look at social media and things of that to compare. There has been some piloting efforts that we've used to identify, to kind of put some basis behind.
What about other agencies of the U.S. government?
If we had access to, like, maybe Internal Revenue Service records, maybe State Department records, immigration records as well, that might be helpful too.
And why would that be helpful?
Well, like, using the State Department records or maybe immigration, we would be able to tell if someone maybe has a physician. For example, we had a physician that we're currently working an investigation in the Houston area where he was billing for Medicare, and then we ended up contacting him, and we found out that he's been in Dubai for several months because we were going to interview him. And so we looked at his claims history, and we coordinated with the Office of Inspector General, who they coordinated with immigration, and found out that, yes, they could give us specific dates of when his passport, when he left and never returned to the country. We'd be able to, identify immediately the provider needs to be put on a payment hold and, ultimately could be revoked for billing for services not rendered.
I appreciate that. Mr. Dixon, as a field agent, what other data would you be looking for outside of the Medicare sphere that might be helpful to you?
I will double down on what Mr. Ward said. We as law enforcement agents do have access to multiple systems where we can work in conjunction with other federal agencies. For example, we work a lot with marshals on our fugitive program. We work a lot with...
Do you interact, though, on a data analytic basis with that data? If you had that data stream coming in, you're talking about physically, you have to go reach to the marshal's office and say, well, who are you working on? This is Mr. John Doe that triggered one of our analytics, produced him as a target. Now I got to call you and do that. That's time consuming. Is there anything you could do on a more proactive, predictive analytic basis that would help you?
Not that I can think of anything on the top of my head, but we do use data analysis in terms of, like, for example, we see dead beneficiaries that are being billed over and over again in our data analytic program. When we analyze the data, we find out that Medicare beneficiaries have been billed thousands of dollars and have died 2 years ago. They're deceased.
And that you don't have access to that information?
No, we do have access to that. I'm just saying that that's one of those.
An example of what you...
Just an example. If we could, I can't, off the top of my head, I can't think of anything else that might help us, but those are the things that we ask the ZPIC to provide. We get a data download, and ZPIC will ask the ZPIC to give us, can you also include the date of death, if possible? So they add that in there. It's helpful.
Thank you very much. I yield back.
Mr. Davis of Illinois.
Thank you very much, Mr. Chairman, and I also want to thank all of our witnesses for being here today. You know, nothing is more important, I don't believe, that the government does to intervene on behalf of individual citizens than the Medicare program, especially as we see the continuing aging of individuals who reach that point and who, without these services, in many instances would have no resources at all to get the medical care that they need. I also remember the days when we used to have the great big discussions about Medicare meals and Medicaid meals and the high level of fraud that existed, so much to the extent that there would be people lined up in some of these places to go in and see physicians. Unfortunately, there have always been a number of people in our country who operate on the principle that if you find a sucker, bump his head. And unfortunately, many of those have been involved in the practice of medicine. They've been involved in the administration and management of activities. And so I applaud the federal government, especially in what we have done in the last few years through the Affordable Care Act to try and put an end to much of this fraud as we can possibly do. And I note that in the last 3 years, we've recovered a record-breaking $10.7 billion, which certainly is not chump change, and it's certainly an indication that there is some effort underway. Let me ask each one of you, I've always been told that an ounce of prevention is worth much more than a pound of cure. What can we do more proactively to try and prevent fraud and abuse? And we'll just perhaps start with you, Ms. McQuaid.
Yes, thank you, Congressman. I think that's an outstanding strategy to prevent any kind of crime from happening in the first place. Some of the things that we are doing is gathering stakeholders together for regular meetings to talk about fraud trends so that we can share information with each other and identify the trends because they evolve. Criminals are very entrepreneurial, and when one scheme gets detected, they move on to another. So that's one thing we are doing, and certainly probably could be done more of in other parts of the country. We also do outreach work to citizens to talk to them and ask them to help us by reading their explanations of benefits and ensure that Medicare is not being billed for services that were not rendered. And there is a website there, stopfraud.gov, and a phone number that they can call if they see that. One of the other things that is being done, HHS, is sending letters to the top billers that can be identified as the outliers in the home health care arena and explaining to them what the rules are in hopes of deterring some fraud. If they might be those outliers because they're engaged in fraud, maybe a letter saying we're watching you and we just wanted to make sure you understood the rules. Maybe will prevent some fraud from occurring. And then finally, under the Affordable Care Act, there is a new provision that helps stop the flow of fraudulent funds in that CMS may now suspend Medicare payments upon credible allegations of fraud. So an indictment can at least stop the flow of funds at that point. So those are some of the things that we are doing, but I agree with you that prevention is certainly a worthwhile endeavor.
Mr. Dixon.
Thank you for that question, Congressman. Let me give you a field agent's perspective on what we do as agents in the field to try and prevent further fraud. We reach out to Medicare beneficiaries on a daily basis. We do a lot of witness interviews. We educate Medicare beneficiaries to look at their explanation of benefits. You see something that you never received, please call us. We will hand out our cards. That's one way we try to prevent. Another very important point I want to make is indicted folks who come in and cooperate with the government. They give us a lot of information about fraud that is just beginning. That's another very valuable tool that we have. We have cooperators, informants. Agents do a lot of outreach while they're working cases, while asking us to give us information, leads, anything new, and also to just watch their benefits and let us know if there's anything
Thank
weird.
you very much.
Thank you for that question, Congressman. Just to bolster what my colleagues have said, we think that more communication is probably one of the things that you can do to help stop more of the fraud, waste, and abuse. But from a ZPIC's perspective, one of the things that we've done over the last couple of years is we've utilized more of the administrative actions and tools that we've had put forth to us. We've utilized payment suspension and prepayment review of providers much more to get a better picture of what they're doing and stopping the money immediately from going out the door. And then we've had more of a use of revocation of the healthcare provider as well. If we tried really hard to make sure that we look at the providers that are in question to see if they do meet the criteria to be revoked and not be allowed to participate in the program.
Thank you very much, Mr. Chairman.
Mr. Marchant of Texas.
Thank you, Mr. Chairman. I'd like to talk about a case that broke in 2012 in Dallas. In Dallas, it was known as the Dr. Roy case, and it involved a doctor who used home health agencies kind of as a recruiting group that fed clients, patients to him. And frankly, it was something that was on the front page of every newspaper, all the TV stations, radio stations. It created quite a level of awareness in Dallas-Fort Worth area about this that we still today in my office get emails and calls from time to time because people they're a little frightened that this fraud undermines a program that they depend very heavily on, and that because there's so much fraud, they're not getting the reimbursement or the care they deserve because there's so many dollars going away from the program that could be plowed back into the program. So the public is very interested. I don't think they're particularly accusatory towards the government in that they think that, we're part of it, but they're very concerned that it takes so long from the beginning of the crime to when the people are convicted, and they don't understand that long time lapse, and I think you can understand that. We have a unique system. You get a bill, we pay it, you come back later and investigate whether it's a good bill. Even if I get an electric bill, I look at my electric bill and I kind of say, does this sound right? And, I make kind of a really quick analysis on all of my bills, and I think everybody here in the room probably does the same thing, and then I pay it. But our system is very unique, and because of that, I understand that there are long delays. Can each of you just talk about how you discovered, those of you that were involved in that case, how you discovered this fraud, and what tools that you used that were at your disposal at that time to solve this case, and what additional tools you might have needed to solve this case faster? And let's start with, I think, Mr. Dixit, you were involved in this.
Thank you for that question, Congressman. I personally did not work on the Dr. Roy case. Well, let me take that back, actually. I did do an interview for the Dr. Roy case in Detroit. Dr. Roy's scheme was so widespread that his employees at some point started leaving with fear of prosecution. One of the individuals, I got a lead from the Dallas office, and the Dallas agents contacted me to interview this particular individual, and that's how I got involved in this case. But let me just go back and tell you that the scheme for Dr. Roy case is something that we've seen nationwide. What we refer to as recruiters or marketers, or they call themselves community liaisons, they go door to door, grocery stores, homeless shelters, solicit Medicare beneficiaries for their numbers. They might pay them cash and or prescription, narcotic prescriptions in exchange for the Medicare number, which is then billed by the home health agency owners for no services ever provided. And Dr. Roy was one of those individuals who would sign off on those prescriptions and also those home health referrals. And this actually, just so you know, is, and I'm sure you're aware of it, is the largest healthcare fraud, home health agency fraud takedown perpetrated by one single doctor. We see a lot multiple doctor cases that come to that amount, but this was one single doctor.
And in 2012, did we have the same level of data analytics then in place that we do now, Mr. Ward?
We actually, in 2012, we had better data analytics than when Dr. Roy was first discovered. He was first identified back in 2010, and a referral was made on that, but it was such a complex case that it required a lot of field investigative work in addition to the original data analytics that were done. From a ZPIC standpoint, we did over 700 beneficiary interviews related to Dr. Roy. That's individual patient interviews to identify where patients weren't homebound and things of that nature. So our data analytics are much more improved from 2009 today, and in 2012 they were much better as well. They improve, you know, on a almost weekly basis.
Thank you. Thank you, Mr. Chairman.
Mr. Smith, Missouri.
Thank you, Chairman Roscom. Thank you to the witnesses for being here. We're here to discuss a topic that is very important to me and the folks that I represent in Southeast and South Central Missouri. We hear a lot about fraud. We hear estimates of more than $50 billion in fraud each year paid by Medicare. We talk a lot about loss to taxpayers, but I want to talk about damage to patients. In many cases, patients are harmed. One important aspect of investing healthcare fraud is whether there's patient harm. In July, I learned that the University of Missouri, where I graduated from, agreed to pay the federal government $2.2 million to settle a claim that their healthcare program physicians committed fraud. According to a U.S. attorney prosecuting the case, a federal investigation found that physicians had not reviewed radiology images. I'm curious how these types of settlements are reached, and that's why I ask you, Mrs. Quaid, can you discuss the considerations you use to determine an appropriate sentence or settlement for Medicare fraud?
Thank you, Congressman. So I'm not familiar with the Missouri case in particular, but in other kinds of cases, in a criminal case, we are governed by sentencing guidelines. And so those will offer an advisory range for what a sentence ought to be in terms of a prison sentence, and will also offer an advisory range for a fine. So that is the starting point for any negotiations in a criminal case. In a civil case, there are a number of different ways one might quantify an appropriate settlement. You could look to the fraudulent dollars actually expended. Some of the False Claims Act permits triple damages, so you can start at that as a triple point, and for the certainty and swiftness of a settlement, come down from that number. Oftentimes, ability to pay of an organization is also a factor that's considered. So all of those things are considered, but I can assure you that at the U.S. Attorney's Office, perhaps unlike private law firms, we constantly strive for what is in the best interest of justice and what is in the best interest of victims, and are prepared to go to trial in cases where we cannot reach an appropriate settlement that we believe meets those aspirational goals.
Is patient harm a consideration in your settlement negotiations?
It is. It is certainly considered an aggravating factor. Under those sentencing guidelines, patient harm is an aggravating factor, and it's something that we would consider in terms of the egregiousness of the conduct.
Do you have a list of crimes that are considered egregious to determine an appropriate sentence?
It's difficult to talk about all of them, but we have a few examples. There's the Dr. Fada case, which in my view is the most egregious, providing chemotherapy to patients who did not need it, some of whom did not have cancer. We had another case involving a Dr. Sabat who installed medical devices, claimed to install a medical device into people's backs, performing back surgeries, instead replaced it with a cheaper material for his own cost savings, resulting in real patient harm and the need for additional surgeries by some of those patients. So the patient harm can really range from a whole number of things: exposure to unnecessary nuclear stress tests and radiation. So it's a wide spectrum of things. But patient harm is certainly something that is considered in imposing any kind of sentence or fine.
Thank you, Mrs. Quaid. Yield back, Mr. Chairman.
Mr. Anasi of Ohio.
Thank you, Mr. Chairman. I want to thank the witnesses for being here. You know, it's frustrating. I was in the healthcare profession for almost 3 decades before I came here. And I know back home people are very frustrated because they know there's fraud and abuse. And as a healthcare provider, I saw it around me. At least I thought I saw it around me, but you can never prove it. So I realize you guys are in a very tough situation, and I appreciate the work you're doing. But the American people are sitting here listening, and look, there are 3 types of people out there. There are those that commit fraud and are caught, and we've talked about some of those. There are those that commit fraud and are not caught, and there are those that don't commit fraud but are accused, which is even worse. So I hear a lot from those that are accused and then are not convicted or committed, and they have to go through a process. In fact, I heard from one agency that spent more in defending themselves in legal fees than the total revenues of the whole company for that year. So those are the issues that concern me as well, too. But that still doesn't mean we shouldn't be going after those that have committed fraud and haven't been caught. And I'm trying to figure out in that universe, those that are caught, we already know those are the ones you're talking about, those that have been potentially said you've committed fraud and then aren't, and then those that we haven't caught. Is there any, and maybe Mr. Ward, can you tell me, out of those that are potential fraud abusers, do we have a statistic that says we have gone after 100 and convicted 10, 5, 20, 30, 70? Is there a number on that at least?
I don't know that I'd be qualified to answer that question.
I mean, because these are the statistics, and these are the things I know would help everybody up here on the dais, and would also help the American people understand we're going after fraud. I mean, if you say that, look, we went after 100 people and we caught 99, that's a pretty good statistic. If you say we went after 100 and caught 5, people are going to say, what are we doing wrong? But the problem I'm hearing today, which is very frustrating for me, and very frustrating for anybody watching this, is that we're not quantifying this in numbers. We're not saying, look, there are, one member up here asked how many people, what's the estimate of fraud, and we're not getting any numbers. So it's very frustrating. You can come here and tell us about the ones you caught, but what frustrates the American people are the ones you haven't caught. And I'd love to hear what we're doing. The other thing that's so important, I also heard this from one of the members, you can catch somebody after they've committed $50, $100, $300 million worth of fraud. You're never going to get that money back. They're going to prison, but we've lost a lot of money. So how do we somehow wrap this package up and be able to say to the American people, we know there's fraud, here's our percentages. I mean, I would have loved for somebody to come today and say, look, we have this analytic procedure, we know that there's 20% fraud, we do an analysis that means we look at 1,000 people, out of those 1,000 people, we catch 200. These are the kind of numbers that make us feel comfortable. Is there any answers you can give me to make me feel comfortable who's frustrated and the American people that are frustrated?
Well, I can say that we have folks back at headquarters who do keep a tab of the complaints that come in, how many cases are investigated, how many are criminal actions, how many are civil actions. I guess in my oral statement I had a quick short paragraph regarding the numbers, but we can get back to you in detail regarding numbers if you want that. We do have folks that will get back to you at a later date on that particular question.
I would appreciate that.
I also want to answer the question regarding the money. I do want to emphasize that one of the mission of OIG agents is to make that trust fund whole. We do want to bring money back to Medicare and all the government programs that lost it. So we work with the Department of Justice and FBI and try, during our investigative process, forfeiture warrants is one of the things that we always do and try and seize and take back whatever we can.
Yeah, and I'm not taking away anything the three of you are doing. I'm very happy to hear what you are doing. I'm trying to figure out the big picture of how we can do it better. But I also want to make sure that any constituent has been accused of fraud. It'd be great to hear how many have been accused, and I hope at some point I can get that information. If they've been accused, and then how many have been convicted. That's an important number, because if we're going after, we could say we're going after 1,000 people, but if we're only convicting 1 out of 1,000, that's not a good number.
Congressman, I believe the conviction rate is around 95% in healthcare fraud cases.
Now, I'm talking about the ones that we go after on a statistical basis, and because I did hear that we don't have that number, I thought.
Well, we can get you those numbers. I didn't come prepared for that. I mean, one of the things that we do is there's several different levels of how the investigative work, and some do not meet, are not egregious enough. We prioritize them in a manner to where some of them can be handled administratively. So I'm not sure if this is the answer to your question, but some of the things when we identify through data analytics outliers or things that do not meet medical policy or are outside of what the local or national cover determination, we do things like we put auto-deny edits into the Medicare claim system, meaning that when those claims hit the system, they're just automatically denied out. There's no cost to process. I mean, they're submitting claims that will be automatically captured and denied, never paid or processed. So that's something we could give you some numbers on cost savings. But then you have other levels where they may require more investigative methods and will require referrals to the Office of Inspector General to look at it for criminal or civil investigation, and then essentially go to the Department of Justice for prosecution.
All right, thank you. I yield back.
Thank you. Just have a couple questions to follow up and then maybe some wrap-up comments. Mr. Dixit, Mr. Reed was asking you about the billing with dead beneficiaries. Can you just walk us through that? It's kind of one of those things, we hear that and say, how can this possibly happen? So what is it that and that seems just a fundamental thing. So what is it that, number one, how does it happen? Number two, how can we be intentional about stopping that one? That seems like it's low-hanging fruit.
Thank you, Chairman. Doctors who actually bill for services not rendered never see the beneficiaries. They never realize that the beneficiary has passed away 4 months ago. They keep billing for the beneficiary on what is allowable under the Medicare guidelines. When ZPIC, sometimes through proactive analysis, data analysis, ZPIC will send us this particular complaint and say something to the effect of, there's a doctor who's billing for dead beneficiaries. That's when we start opening the investigation. Of course, we go to the beneficiary's home, make sure that we go to Vital Statistics, other federal, state, local partners that we work with, and get the necessary documentation to make sure that the beneficiary is deceased. The reason it happens is because the doctor never sees anyone to begin with.
How is it that, I understand your point. How is it possible, in your view, or Mr. Ward, weigh in here as well, how is it possible that there's not, I mean, at some point the Social Security office makes a declaration that this person has passed away, and there's a recognition that that person has passed away. How is this continuing to be possible? Can you just walk through the mechanics of it when everybody else knows that the individual's passed away, that the payment system doesn't know that the individual's passed away?
Well, one of the things that we've noticed from the ZPIC standpoint is that we see there's a delay in the Social Security databases known as the Common Working File, which links back to CMS's files, and updating. So sometimes you can have a delay in a report of the death of a beneficiary, sometimes 60, sometimes 90 days. And in that period of time, you can get those billings and the system won't recognize it.
Okay, so then can we at least get some comfort in the knowledge that after that 60 or 90-day period, those kinds of claims false claims are not happening anymore?
Yeah, yes, once that is set in a system where the beneficiary is deceased, those claims should be kicked out through edits that'll show that the beneficiary is deceased and that it's not a valid claim. But on occasion, sometimes, if that information is missed or if certain modifiers are put into place, claims can go through the system. There are some occasions where when there's hospice-related or sometimes durable medical equipment where services may have been rendered and then the beneficiary ends up being deceased where the claim will continue to pay.
For how long would you estimate?
Maybe 30 days, maybe 45 days.
Okay. So, Mr. Dixit, did I overinterpret your response to Mr. Reed? I thought you said that this could happen for years, and what Mr. Ward is saying is that it's a shorter duration than that. So, what's your view?
I guess what I was trying to say is that there's multiple beneficiaries. I might have misspoke. Multiple beneficiaries that are billed every 2 to 3 weeks. We don't see a dead beneficiary being billed for 5 or 6 years. I don't have the exact number on the top of my head how long they actually bill a dead beneficiary for. But what we do see is, like, for example, a doctor that I worked had 1,700 beneficiaries. He saw 1,700 active beneficiaries. But he was not seeing all these beneficiaries. So that when a person passed away, there's multiple beneficiaries that are passing away. He would keep billing them. So we have close to about $200,000 in billings within a span of 60 days for multiple beneficiaries that have passed away.
I want to piggyback a little bit on Mr. Renace's point a couple of minutes ago, and I think that there is I think what is actually emerging is a consensus on this issue, and that there are a lot of people now, and it's a consensus that's based on necessity. You know, in the old days, there was a lot of money around Washington, D.C. You know what I mean? These budgets were flush and so forth. And now with this increasing downward pressure from a financial point of view, I think folks are looking over the landscape saying, we've got to do things better, smarter, faster, and cheaper, and more efficiently. And the first place to start is the notion of not paying people who are ripping off a system. You know what I mean? That is just so intuitive, and that's why you hear this unanimous cheering for you, but also asking a very simple question: what can we do? What can we do more to help you? So what recommendation would you have, each of you? Ms. McQuaid, let's start with you. You kind of got into it a little bit with Mr. Davis from Illinois in that he was asking you a question, and your response was what you're doing, which is, hey, listen, we're all in the business of selling, so good for you. But can you give us a sense of what do you want us to know? What is helpful for us to know moving forward?
Well, we appreciate the investment that Congress makes into our work. And as you know, the return on investment is $6 for every $1 that is spent in terms of recovery. I like to think that the work we do, and when we publicize our work with convicting doctors and other healthcare fraud criminals, that has a deterrent effect on others when they see that there are criminal consequences to that action. So I think continuing to fund our work is one thing that can be done. But of course, that is more of a pay and chase model that occurs after the fact. One tool that would be helpful to us is to continue to enhance the data that we have available to us. An emerging area is pharmaceutical fraud, prescription drugs. I know in Michigan, our electronic database that doctors can enter data into for prescriptions is incomplete and imperfect, and an improved database would help us to see which doctors are prescribing medications. So that would be one tool that would be helpful to us to improve our work.
Okay, improved pharmaceutical database. Okay. Mr. Dixit, what do you think? What do you want us to know?
Thank you for that question, Congressman, and thank you for your continued support for the OIG and its mission. As a field agent, in my perspective, more agents, more resources, more boots on the ground is a force multiplier for agents who are doing this work. That would help every agent in every jurisdiction to investigate more, spread the wealth, so to speak. Will be more efficient and effective.
Okay. Mr. Ward, how about from your point of view?
You know, I can say over the span of my career, I've seen very many iterations of how this program has progressed and how I've seen fraud progress as well with it. And I can say right now with our work that we do with the CMS and with our law enforcement partners that it's probably the most aggressive that it's ever been in my career as far as how successful we're being. So I appreciate your continued support. I think probably the most important thing to continue this fight is that we do get your support in collaboration with CMS and with the OIG and the Department of Justice as well.
Yeah, I think you know, one of the areas is kind of in closing. One of the areas that Mr. Blumenauer and I are working on, a member of the Ways and Means Committee from Oregon, and that is a secure ID bill. In other words, having using the same technology that the Department of Defense uses to limit access to sensitive places. It's well deployed in the federal government, and we've got a pilot program that says, let's use this in Medicare, and let's make sure that there is data that matches between a beneficiary and a provider so that you know, the sale of a Medicare number underneath a bridge somewhere to manipulate and rip the system off, that can't happen. So that is part of the legislative remedy. I think this idea of more boots on the ground, I understand. We wrestle with that same question on intelligence issues, national intelligence issues, the tension between the data side and having people in country and so forth. You're describing essentially the same thing. There's an element of prevention that really I think we can be very satisfied with, and these numbers are so big they just take your breath away. So while they are impressive, the work that you're doing, we would be so much better off if we basically put you out of business. If it were up at the front end and these claims data were so tight and so well screened and so intuitive that you the types of fraudulent claims that you had to chase down were just de minimis. That would be so satisfying, I think, all the way around. And then we could have great debates in this Congress about how to spend an additional $60 billion that we could save, and we could figure out ways to do it much more efficiently. But on behalf of the entire subcommittee, thank you very much for what you're doing. Number one, the work that you're doing and your willingness to spend time with us today. I appreciate it. Committee's adjourned.